Our gLocal solution room today is one of two that we've run in our centre, and we're just outside the 7th of June window, but we had special permission to be able to actually do that. And I'm just going to introduce the concept of the gLocal solution room in the context of what the JBI does and how we try and link evidence to implementation. So I'd like to welcome you to JBI. This is Professor Zoe Jordan, who is the Executive Director. And essentially at its core, JBI is concerned with improving health outcomes in communities globally by promoting and supporting the use of the best available evidence to inform decisions made at the point of care. That work begins and ends with the needs of those working and using healthcare services. And what JBI centres globally try to do is respond to those clinical questions and practitioner questions and service user questions to provide high quality, reliable information that is useful where it counts. As a snapshot, if I just tell you who we are, it's a global organisation that promotes and supports evidence-based decisions to improve health and health service delivery. We do that through a range of different approaches. So actually looking at evidence, education, the software that might help support those initiatives, and also primary research. JBI works across 40 plus countries globally with universities and hospitals through the JBI collaboration. And our aim is to improve health outcomes internationally, where we're able to do that by sharing our information and synthesis and implementation issues. So for those of you who don't know what JBI is, our vision is actually to provide better evidence, better outcomes and a brighter future. And we do that through our mission of promoting and supporting evidence-based healthcare globally. JBI is based in Adelaide, in Australia, at Adelaide University, but has over 85 entities across the world that actually join in that collaboration to move evidence and implementation together. What we try and do is focus on the fact that healthcare synthesis is more than just being effective. It's also about how big is the problem, why is there a problem, and what's its likely cause. How do we make patients feel what they do and what they prefer, and what's the impact of the context of the work that we're doing. So ensuring that we take all aspects of evidence across its likely implementation into healthcare. This is the JBI model of evidence-based healthcare, and it has 5 segments, but at its heart, what we're actually looking at is whether or not the evidence we synthesize and want to implement is feasible, appropriate, meaningful, and effective. It includes different types of evidence in terms of evidence generation, as well as evidence synthesis. We have programs that look at the implementation of evidence into practice, and also how evidence is disseminated. So despite organisations like JBI and Cochrane, there continues to be a gap between primary research that is produced by researchers and clinicians, the synthesis of that evidence, and how it actually gets translated into practice. And although we've been in existence for over 30 years, we know that that gap still exists, and that it takes a considerable length of time for research to be implemented. And the average is around about 17 years for about 14% of the published evidence. to get into practice and be useful. And that's quite difficult because it probably means that it's not timely. If it takes 17 years, it's out of date. And so we're always running to catch up to try and ensure that evidence gets used effectively and in a timely way. And so this particular implementation framework that we try to use really focuses on the fact that audit and clinical feedback is a really useful approach to implementing evidence into practice, recognising and understanding that the role of professional culture, organisational support and leadership in the process is absolutely essential to its use. The JBI evidence implementation project is clinically oriented, so it's driven by clinicians, it's team-based, and it's aimed at implementing the best available evidence into an organisation's systems and processes of everyday care. These projects in the format of the JBI actually are very similar to those used within the NHS that use the Plan, Do, Study, Act approach, and they emphasise clinical leadership and evidence-based practice change. The implementation approach is firmly grounded in audit feedback and re-audit cycles, and ensuring that we actually try to see how we can improve the implementation over time. So, as I said, JBI is a worldwide global organisation. We have global partnerships to try and ensure that the work we do is shared across the globe. And the gLocal Solution Room is one means of actually doing that. It happens annually so that we can actually share best practice and learn from each other across the globe. There are 90 plus partners, as you can see, now basically featured in North America, South America, Africa, Europe, Australasia, the Far East and the Middle East. So the collaboration's the largest global collaboration to integrate evidence-based healthcare within a theory-informed model. We all promote and support the use of evidence-based healthcare globally, and each of the entities, so each of the centres, like the one at University of West London, leads different initiatives within their region, state, country or specialty. And this particular focus today is on the work that Amalia leads in relation to diabetes care with our partners in the NHS. So what is glocalisation? So we're thinking think global and local. So actually trying to make sure that what we try to do is focus our activities on things that can be shared across. So glocalisation was popularised by the work of a sociologist called Roland Robertson, who traced its roots from a Japanese business term called jakakua. And if you think about what we do within the NHS in terms of many of our quality improvement initiatives, many of them actually come from quality improvement within industry, some of which is based within Japanese models. Glocalisation stresses the idea that contemporary globalisation influencing the local levels of society and localisation. So what does that have to do with evidence-based healthcare? So I think the JBI model focuses on the critical relationship between research and practice, and then the yellow wedge at the top, which looks about both global health and the local use of evidence. And evidence-based healthcare begins and ends with the needs of health professionals, health services, and health service users. If researchers and synthesists aren't engaged with those who are working in practice and aren't responding to your knowledge needs, then we will never actually achieve sustainable improvements or impact where it matters most. That's why our events such as the Global Solution Room are really important. We try to answer the right questions that matter as they relate not only to effectiveness interventions, but the feasibility, appropriateness and meaningfulness of those interventions to ensure that our implementation efforts are a success. What we hope is that working in collaboration with clinicians, that we can determine what the questions are we need to answer, how they can be supported and then implemented back into practice. So thinking about working globally, our application of evidence is key, and JBI knows that it's our responsibility not only to provide health professionals with the best evidence, but to support them in its use. And that's not possible without connecting in person, without acknowledging and accepting that different cultures and clinical environments present different challenges. And we hope that this event contributes to overcoming some of the barriers and help us to understand the challenges that you're facing. The idea of the solution room came from a conference session concept and was then actually taken forward by JBI. Doesn't exactly follow the same format, but it is very much about being solution focused and pragmatic, and being important that we reflect real life challenges with our NHS partners in this country. So I hope that you enjoy today's session and that you take the opportunity to look at the wider work of JBI, because there is a huge amount of good work out there, and some of which may be very relevant to your areas of practice. At which point I will actually now hand over to Amalia to take this next session forward. Amalia, your microphone's off. Your microphone's off, Amalia.
Terrible. It reminds me COVID times. I had to, I'm going to share again. Apologies for that. So what I was I'm going to say, it's like I'm going to take you to a kind of traveling through our work that was the PhD thesis of Arif, that he now got his PhD and defended the work. While we were doing that work with Arif, we also having this collaboration with NHS, where we were feeding some of the information or the information to them, and then where they were kind of including some of those elements to their practice, something that Rosa, Ala, and Adama is going to talk about. It's customarily to present what diabetes is. I'm not going to stay here too long. Quite a lot of you may know or been aware about the challenges about the diabetes and the inability to control blood glucose levels. I think Rosa and Adam is going to talk a little bit about it. What it comes down, it comes down to the limited production of insulin that that cause this chronic condition. Usually the risk factors, it's older or 40 and over, adults. However, I have to say for the South Asian population, that increase it's so much higher, or the risk factors are so much higher that this age, it's 25 for this South Asian population. Rosa is going to talk about the why South Asians, and she's going to specifically focus for their part. But for our part, what we've seen, it is that the South Asian, Afro-Caribbean, and Black origin, they do have higher risk factors. And then how we've started this trip and systematic literature review, it was that there were quite a lot of comorbidities and mortalities that been related with diabetes. And what it struck me, and still I cannot really comprehend, that there are about 9,000 amputations per year in UK, but also other comorbidities, and the staggering cost of the NHS, that it's 1.5 million per hour. And actually that it's 10% of the NHS budget, it's been dedicated to the management of the type 2 diabetes in UK. Staggering amount. And I think that probably Rosa is going to talk more about the diabetes. And then we are estimating that currently there are 4.4 million of diabetics in UK, and about 1.2 million have been non-diagnosed. So the main pointers of this work is that these populations, South Asian, African, Caribbean populations, they're immigrants. There is this migration, and there is an element of acculturation. And why I'm saying the acculturation? Because type 2 diabetes, it's a condition that can be managed through the lifestyle, or the modifiable factors are associated with lifestyle. If somebody would include lifestyle, diet and nutrition, this is the lifestyle as well. And that what we've seen is we would like to see how that affects this acculturation, the risk of developing type 2 diabetes, how the lifestyle would contribute to this diagnosis. So we'd be looking at the literature, conducting a systematic literature review. We've been looking at epidemiological studies that we examine this trend and the risk factors, and also we'd be looking at the population as such in order to find out their habits, their barriers and facilitators in order to manage this type of lifestyle. It kind of disseminated also to some other programs that we do have, and there are actively now within the NHS partners, and we're lucky that we're part of it as well. So the systematic literature review that Arif and the team did, it was to examine the risk factors of type 2 diabetes among this population group of immigrants across generations in relation to the dietary and other lifestyle factors that included smoking and consumption of alcohol. And what we've seen from the literature, it's also that within the population of the South Asians, for example, some groups like Bangladeshi, they had higher risk factor than Pakistani, than Indian, than Black African, and so on. So we've seen that. And we've conducted and we've included some, of course, criteria in order to select those studies. So we focus on that population, South Asian and African and Caribbean. We're looking at studies that would include first, second, and probably third generation. That would be also an interest of, and we're looking at these odd ratios or hazard ratio within their studies. We've included mixed method, either quantitative or qualitative, and I would be looking at original studies. And as in any systematic literature review, we've conducted the PRISMA, where we had some records there, like 6,000 and so on. We've fully screened the all the hits, and we've ended up with 9 eligible articles to do the data synthesis. It was quite unfortunate that all the studies, they were quite heterogeneous. And as everybody researched, the dream it is to look at this fantastic forest plot. Unfortunately, we were not able to do so. However, we've observed quite significant information in order to take at the second step what next for this after this systematic literature review. So most of the studies, they've demonstrated that the second generation of these ethnic minority populations demonstrated a lower prevalence of type 2 diabetes than the first generation. For all populations, and we'll see that there were some exceptions. Something that it was quite significant that we've seen that the larger reduction across those generations were observed among Moluccans in Netherlands, where the prevalence of type 2 diabetes decreased from the first generation, that it was 23.2% to 0.9 on the third generation. And there were also exceptions to that specific kind of trend. The exceptions with the Japanese Brazilian, where the second generation did have a similar or higher prevalence than the first generation. And we've looked at these Filipino Americans as well, and so on. So how we looked at those, so we can have some sort of numbers there. I've selected some of those, some of that information, and we can see that one study within the UK that was looking at first and second generation, the first generation was 10%, and the prevalence were a second generation 7%, and that it was related to Black or African Caribbean, whereas the South Asian, they moved from 14% prevalence to 11%. So we can see that trend within those findings, and so are Filipinos also within the USA study. So we wanted to look closer to that and have a look at what actually did change between first and second or third generation with those. And what we've done is we wanted to find out a bit more on how this specific lifestyle, the acculturation that we can see from the first generation to second generation, how that may be affecting this prevalence of type 2 diabetes. So the next step to that, it was to look at longitudinal studies and investigate whether the prevalence of type 2 diabetes among these populations was changed between the lifestyle, like the exercise that people would have, or about the customs on eating more vegetables. We'd be looking at these modifiable factors that did occur between those generations. So we would be looking at those gender, about the country of residence, sleep quality, blood pressure, and so on. And that is the study that was done by Arif as well. Arif, are you going to be able and take the lead from now on so you can present the phase 2 study?
Thank you so much, Amalia. And
Yeah.
I am Arif, and thank you all of you as well. And this is from my PhD research, the findings, as I am going to present right now. And it is about longitudinal study. It is the data comes from UK household longitudinal study and over the time frame 2016 to 2019. And it is a big data set, and the analyzable data we got for our variables without missing data, it is about 4,332, and it is with the ethnic minority adults like Asian, African, and Caribbean over the age 25 and above. Those have no diabetes at baseline. And in this study, we did chi-square test and logistic regression analysis. And this is the slide. It is showing that chi-square distribution. It is, you can see the p-value is less than 0.000. That means highly significant. And the type 2 diabetes prevalence is higher in first generation compared to the second generation, and it is 5% in first generation and 1.9% in second generation. So it is significantly quite higher in first generation, which is already Amalia demonstrated in systematic literature review as well. And after that, we did the logistic regression, binary logistic regression. We fitted 5 different models. Model 1 is the unadjusted model, and model 2, model 3, model 4, and model 5. Subsequently, we adjusted for different risk factors, as already Amalia mentioned, gender and residence type and country of residence and chronic illness and high blood pressure and age. Model 5 covers all the variables, and it is the fully adjusted model. What is rounded with the circle, you can see the those first generation consume vegetable less than or equal 2 portions per day. They showed that the ORS 1.92, and it is significant at 5% level in the finally adjusted model or fully adjusted model for all the variables. And that means even though first generation and second generation, they maintain same level of vegetable in a day, still type 2 diabetes ORS is higher in first generation. It is 1.92. And on the other hand, we got a significant result which is really mentionable. We want to show that it is in the red circle, bottom right corner of the slide. It is the respondents who consume fruits more than 2 portions per day. They exhibit that the higher ORS in first generation 3.72. This is also significant at 5% level, and compared to the second generation. Now question is that even though they followed more than 2 portions per day, it is a recommended level of fruits consumption. Why 2 different generations got different ORs? This is a confusing or paradox. And this is the result. This is the findings which actually drived us to think about why it is happening. It is actually due to their food quality and their cooking style and fruits and vegetable consumption, how they preserve, how they process, and these elements actually we actually thought about. And due to that, we actually did this is what we wrote here. First generation groups had greater odds despite similar fruits. And another finding, it is not mentioned in the table, it is that over the age, as the age increases, type 2 diabetes prevalence increases. It is in the younger adults, it is 2%, you can see, and when it is 60 plus, it is 8.3%. That means as the age increases, type 2 diabetes prevalence increases. And due to these findings from the longitudinal study, we actually come up in a qualitative study to explore why it is happening, even though they maintained same fruits and vegetable consumption level, why first generation got higher odds. And it is due to that cooking practice, food quality, and duration of exposure to the risk factors, and migration related factors, and some other generational habits, their behavior, lifestyle, and health status, gender, and age relevant factors. And this demonstrates us to conduct one qualitative study. Please, next slide. And this is about the study aimed to examine the dietary habits, food preparation practices, and perceptions of immigrants, their descendants who live in London. This is data only for those ethnic minority people live in London. And it explores their food preparation, cooking method, their ingredients quality, nutrient values, and sources of food. Is it homemade or processed food or takeaway, and to investigate the awareness of the relationship between food practices and the getting the type 2 diabetes. This is about the qualitative study, and their barriers and facilitators also identified. And for that, we collected data for 20 respondents, adult respondents. Those belong to South Asian, African, Caribbean, those live in London. Belongs to first generation, second generation, third generation. And we analyzed the data using thematic analysis, and it is regarding food practices, cooking style, and ingredient awareness. Slide. Okay.
Okay.
Amalia,
So yeah, thank you, Arif. I'm going now to present the thematic analysis, which was done as Brown and Clark, actually. So we followed the 6 steps of the thematic analysis, and then we would be looking at dietary habits. So we're looking at fruit and vegetable consumption, and the levels that they do. And with what we've observed, for example, the third generation, they usually meet from the qualitative data. They're aware of the portions that they would supposed to eat or they consume, and they would meet those 5-a-day fruit and vegetable consumptions, whereas the other generations they didn't. Some of the staple foods that may be used, it's carbohydrate items. And what we've observed from those interviews, it's the other generations, the second and third generation, they were eating less of those carbohydrate items that the first generation consume. And that it's an indication how this acculturation affects the dietary habits. What we've seen is that there was quite a bit of protein that was consumed. The second and third generation, they were consuming more of the meat products, whereas the third generation didn't consume that many. So what we would be looking also, another theme of these dietary habits, is that there were some barriers to follow these different dietary habits. And one of those, it's about their culture. The culture they were determining the choices, the food choices, or healthier food choices. And the second and third generation, they were different on that. And that type of element actually was linked quite well on some of the approaches that we've used with the West London NHS in order to contextualize some of that information, some of the information between the fruit consumption and the vegetable and staple food and the carbohydrate consumption in order to make those changes. The other element is about the awareness of those dietary habits, and quite a few people were not aware of those elements, how diet, for example, would go about, and their accessibility to the fresh foods, especially for the first generation, and the look of the traditional ingredients as well. Oops. Okay, I couldn't shift the slide. Now we would be looking also about the theme of the lifestyle habits, and those habits, they were related to the physical exercise, and we've seen that the third generation wasn't so keen to participate, whereas the third generation, for example, we've seen that they were exercising more. Alcohol was also consumed the first and the second generation, especially from the Caribbean and African side, and the sleeping habits that there were was for the oldest generation rather than the third generation. So we would see also that the lifestyle habits, they change between those generations. Now, what were the barriers? What sort of stopped these people in order to adopt those healthier lifestyle? So weather, as was also quite important, and time that was available to them. There were also culture that play a role, and those were the main barriers for, especially for the first generation, to follow, not to follow, but to actively participate in the change of those lifestyle factors, something that supported changes, and how those the approach were implemented from the West London NHS actually to understand the population. And the facilitators for that physical exercise, it was actually the awareness of the benefits and the environment that they were also, if they were available gym or playground, the accessibility of those. The what Arif was saying, it's actually there is a paradox between the vegetable consumption, of fruit consumption, and the prevalence of type 2 diabetes, because we see in the first generation that were older. However, the Model 5 did take into account the age and the actual odds that were still higher, considering or equilibrating that with age. So what we would be looking at how these people prepare that meal. And we've seen that the kind of way that they were cooking, the frying and the grilling and the roasting, that it was really important for the first generation, and the first generation weren't aware of the changes that they can make into these cooking methods. Whereas the third generation, they were more aware and they were ready to adopt or adopting already healthier cooking preparations and not the traditional ones. Some of the cooking practices also, we've seen that their hygiene approach and the way that the dirt or the pesticides or those type of quality of ingredients would be a part of making changes in their diet. We've seen that the younger or the third generation were more aware of those practices rather than the first and second generation. So that it was quite a strong element on the findings of those qualitative research findings. And the theme that we've seen of the strategies that they applied in order to maintain this quality of ingredients and nutrition, it was that if they would check expiring dates, if they would check, if they would go for cheaper ingredients, would they have a priority on the quality or not, or the nutritional value, or the choice of the unhealthy ingredients. So we could see some of those sub-themes, and the third generation demonstrating a better awareness of those choices. The other elements that would be looked at, were looking on where these people will take those foods, if they are home prepared, or they are going to go for the takeaway or dining out, or they would be looking at processed foods. So we've seen the takeaway, it's highly processed food, and we know about really well about these type of foods that there were not of healthier options. And we've seen that the first generation, they were go for homemade foods. And there is another paradox here, and how it is possible to have homemade food that they actually increase their risk for type 2 diabetes. And we would go back to what we've observed about these cooking processes and how they would prepare those foods. Whereas the second generation, they were mixed, homemade and also take away, and the third generation, they would have more balanced and healthy items from those choices. We've been looking also at their awareness of the ingredients and how those would affect the risk and how they affect their food choices. And actually, the third generation, they would have mixed opinions about the importance of ingredients, about the importance of carbohydrates, about the processed food and those cooking techniques. And we've seen that the second generation, actually, they knew better how to get those choices, and how they would balance, and the third generation. And also what we would be looking at these views, we would be looking at how usually the third generation that they've been many years in this country, we would see a kind of what type of acculturation that they would have. And we did compare also their views and diets and lifestyle with the third generation, with the younger population, the people they migrated in UK between now. And I think that we've chosen like the last 3 years when the study was conducted. Arif, correct me if I'm made a mistake here.
That's true.
Yeah, so what we've seen, it is like that the third generation, the younger population, they were more aware about these healthy choices and lifestyle. So we can see a lag of the older generations on getting into an education of knowing what is important and how they can protect themselves from these culture recipes that excuse me, that they would look closer to the fried food and closer of using ghee, for example. We had some information of those practices, and we try to communicate that also to our NHS partners, and actually apply those, as you will see later on when Rosa presents the findings, apply that to the suggestions for that program. And that that the duration of living in UK actually was a quite important element of that risk factors. So we can summarize about this investigation is that the older first generation participants consume more homemade food. However, that it was heavily relied on frying and high fat cooking. The younger generation adopted a hybrid of those westernized dietary patterns, and the third generation, they were demonstrated greater awareness of nutrition, of food quality and food hygiene. The younger generations, they were adopting more of steaming, air frying, and these healthier preparation methods that we did apply those into the cooking classes, or we did apply that into the my slide doesn't work. I'm not quite sure. My computer, yeah, they demonstrated that. So the third generation were also more important to check the nutritional label than the third generation that was looking for fresh ingredients and so on. And here you can find our publications that they were culminated from this type of research. And I would stop sharing now, and I would move to the next presentation with Rosa and Ala, that they will present how part of that information and their experiences as well culminated into changing habits. Thank you.
Thanks so much, Amalia.
Thank you.
Thank you, Arif. Lovely.
Thank you
Let
so
me
much.
just grab
Thank you.
my screen. Perfect. Okay, Anila, if you don't mind just making sure you can move yours around as well. Perfect. Great, thank you so much. Let's go back. There we go. Lovely. So, thank you, everyone. My name's Rosanna. As we've mentioned, I'm a health improvement practitioner for the Diabetes Health and Wellness Coaching Service, and my colleague Ala is also here. You want to introduce yourself, Ala?
Hello everyone, my name is Ala. I am a diabetes health and wellness coach within the NHS.
Perfect, thank you. And we're based in Ealing, West London NHS Trust, and we're within a smaller cohort, Ealing Community Partners. So we really are speaking to you today around how we've implemented the findings from Amalia's synthesis into ensuring that our service is the most appropriate for the communities that we serve, and how we've worked in partnership with West London to ensure that our programme works alongside our academic partners within the borough that we live and work. So without further ado, I'll get started. So Amalia has given us amazing context around the prevalence of diabetes, but just to go back to a similar slide, which I know she has already covered a bit earlier, but we have we have over 3 million people living with diabetes in England, and so this is a large percentage of our population. So it's a real priority in terms of chronic conditions for the NHS. And we also have an even larger population who are at high risk of developing type 2 diabetes. So there's a big problem of prevention, and at the moment there's a real push within the NHS to move towards preventative services where possible. It's also a really costly condition, mainly related to the complications that can come with diabetes, like amputations, neuropathy, but it's costing around £14 billion a year just to treat diabetes and its complications. So it's a real priority within our services as well. And as I mentioned around the preventative shift, this is really aligning to the NHS 10-year health plan. So there's a real boost in funding for primary care and community services. There's a push for neighbourhood working, so taking a more place-based approach and ensuring that we're collaborating with not only other services in our local area, but also community partners, voluntary services, the side in academia. So that's why we built our partnership with West London University as well. And this is to really provide that wraparound holistic care for our patients, so that and to reduce barriers to access of multiple services, better serving the needs of our community. There's also a shift towards using more digital services. So Adama is going to speak to us a bit later around how they're using continuous glucose monitoring within their services. And this is a really key digital service for those with diabetes to better manage their condition, and to really make use of the digital tools that we have available to us. So yeah, our service, we really focus on our partnerships and collaboration, and I think we take a real proactive approach to dealing with that within our diabetes coaching service, and applying partnerships where possible, thinking of comorbidities within our service. So we build partnerships with mental health teams, with drug and alcohol services, to see where we can join our care up and reduce barriers for our patients as well. And what I'm going to speak about today is a perfect example of how we've done that with the university. So just to provide a bit more context around Ealing, which is where our service is based, we are an outer London borough, so home to almost 400,000 residents, with a large Black and ethnic minority population, particularly South Asian population in and around the west of the borough. It's quite a highly deprived community, and around 1 in 10 adults are diabetic. So as of, this is my most recent look at our prevalence data, we had 36,297 patients registered with their GP and Ealing who also have a diagnosis of type 2 diabetes. So we can really see the scale of the problem here. And looking a bit further at the demographics of who our diabetic patients are, this is just from our health inequalities dashboard. We've got an amazing BI team within our service, so we can really look and interrogate the data on who our patients are within the borough. And you can see here that we've got alongside deprivation, there's a really large population. These are all this is within the diabetes cohort, so this is out of patients that are registered with a diagnosis of diabetes. 12.1% of those sit within the second quintile of deprivation, so much more towards the most deprived areas of the borough. And you can see here that the Asian and Asian British and Black British ethnicities are much higher than the Ealing average in terms of diabetes prevalence. And this is another piece of data that I just popped together for this presentation. So we've got alongside the bottom there is the main key areas and neighbourhoods within the borough. So you can see alongside the bottom there, we've got North Southall has the largest prevalence, and that's within the Asian community specifically. So 17.1% of South Asians within North Southall have a diagnosis of diabetes, and this is our 25-26 data. And this isn't, this isn't just related to the medical reasons. This is also thinking about the wider determinants of health. So outcomes are not just shaped by medical prevalence, it's also thinking about those cultural, ethnic and social determinants. So we have a higher risk within the South Asian community, as Amalia's brilliantly demonstrated there. But this is also shaped by people's dietary patterns, social norms, and people's language barriers and access to care. This is not only around prevalence, but also outcomes. We know that the outcomes for diabetes are also worsened within the Black and South Asian communities. And as I've shown by the data previously, this is really closely linked with income and socioeconomic deprivation. So it's really important here within our service that we consider, this is the Dahl, Green and Whitehead model along the side here, that we consider the wider determinants of health when we're linking with other partners. So for example, linking with employment support services so that our patients can be signposted to improve the social side of and to improve things like employment within our cohort. So we try to take this really holistic approach, acknowledging that our patients are going to be affected by many things that aren't just the medical side of their healthcare. And within our within Ealing Community Partners, we have 3 distinct diabetes services. So firstly, we have the Diabetes Education Service. This is an accredited education programme where patients will attend for 4 sessions, and it's delivered 6 days a week. It's delivered in multiple languages as well. And here they'll be learning much about diabetes risk management and its complications, including from a multidisciplinary team, including dietetics and podiatry as well, because we know that it's really important for patients to be thinking about moving towards checking their feet on a regular basis, just due to further complications that can happen in terms of amputations if their diabetes does become more severe and less controlled. We also have DICE, which is the Diabetes Specialist MDT team. Adam is going to be speaking more about DICE later. She's the lead for that service. And then we have our Diabetes Coaching Service, which is the team that me and Ala work for, and this is looking at behaviour change support, supporting people to self-manage their condition. We have a real focus on increasing people's skills and motivation, but Alaa will go into this in more detail in a minute. And through these 3 services, we really work closely in collaboration together to bring about this integrated, person-centered approach within our community, because we know that our community is much more at risk of diabetes than others in London, but wider in the UK as well. And the reason we've brought about different services is in order to cater to people's differing needs. So some people, might need extra support in terms of education, but our coaching service is there to provide increasing in motivation for change and for lifestyle change. And so we might be working with a different population between those services, but what we do by providing multiple points of access is really support that wraparound care. So I'll move on to pass over to my colleague Alaa, who's going to speak to you more about the service we offer and the approaches we take to embed evidence throughout our coaching service.
Thank you, Rosa. So I'll be talking about what is our service. And to start with, it's important to define what's health coaching. Health coaching, basically, it's a distinct intervention. It's a collaborative and a person-centered approach. It helps the patients, to support these patients to identify, pursue, and sustain health-related goals. Instead of giving them advice, the coaching focuses on helping the patient develop their skills, their confidence, and their motivation required for a better self-management. This approach is grounded with using evidence-based coaching approaches, such as motivational interviewing and as well behavioral change models, and emphasizes basically partnership, self-discovery, and accountability. So when it comes to diabetes care, many individuals know what they should be doing. However, translating this knowledge into sustainable action can be challenging. So this is where our diabetes health and wellness coaching comes. We bridge the gap between the knowledge and the behavior by supporting the patients. So that's what we offer. We offer a personalized one-to-one health coaching over 12 weeks. And as well, this is our coaching program. It's responsive to the cultural, social, and economic realities of our patients in the Borough of Ealing. And part of an essential part of our coaching is the cooking classes, which delivered by the University of West London with Amalia's team to help the patients make everything they learned come to life with improving their cooking skills and their as well food choices. So I don't know if I can move to the next slide. Okay, so basically our service criteria is for adults above the age of 18 living in Ealing or registered with a GP in Ealing. They have to be diagnosed with type 2 diabetes, and as well the service is designed to be accessible for different populations because we offer tailored support regardless of the background or the experience of diabetes management or how many medications there are on, or if we can offer face-to-face, we can offer as well phone calls or video calls with the patients. So our refer criteria is fairly easy. There is a referral form that the patients can complete themselves, or if they are referred by a GP, we give them a phone call to arrange the first appointment. After that, we book their appointments over the 12 weeks program. We have continuous weekly or bi-weekly regular coaching sessions. They attend the monthly cooking class offered by the University of West London. And after that, after the 12 weeks, they finish the program. We have an assessment in the beginning and the end of the program as well. And we discuss their self-management alone after they finish. So again, just to go over a bit what we talked about, it's the health coaching is aimed to improve the health outcomes of individuals by helping them set their own goals, their personal goals that's basically related to their own lives. For example, we focus about what they want to achieve when it becomes it's not quick fixes, it's more about long-term changes in their life. So we encourage self-discovery and accountability, and we build a rapport between the coach and the patient. So for example, when we usually ask patients about what does a healthier lifestyle look to you, patients rarely begin by discussing biomarkers or clinical targets. They mostly talk about things such as regular exercise, cooking more often, sleeping better, even like being able to look after their grandchildren. So it's more about meaningful aspects of their daily lives. So this is what a key principle of coaching is, that behavioral change is mostly effective when it's linked to outcomes that patients personally value. So what is our role as coaches is that we link between meaningful life goals and how they can do self-management behaviors when it comes to diabetes. So we all know the importance of a healthier lifestyle. Healthier lifestyle is very important as well with improving diabetes outcomes. It boosts energy and mood, it supports mental health, it reduces stress, it improves sleep, and it's increased overall physical fitness as well as maintaining healthy weight. And the list is very, very big when it comes to a healthy lifestyle. So what we do as a WhatsApp program, it's 12 weeks program. It's one-to-one sessions. These sessions can be, like I said, weekly or bi-weekly. They are personalized. They are tailored toward the patient's priorities and what they want as to achieve. The goals are developed through techniques such as open-ended questions, such as affirmations, reflections, and summaries. It's important to make sure that the goals the patient identify are realistic and achievable. And as well, like the goals can vary a lot. It could be from increasing daily walking, it could be reducing sugar, it could be improving their adherence to medications or planning their meals more effectively. So the patient takes ownership of their own goals as well. We know that behavioral change rarely follows a linear pathway. Patients frequently encounter different barriers. It could be emotional, it could be social, or environmental, and this can affect the process. So during our coaching session, we explore these barriers collaboratively, and we use structured kind of problem-solving approaches to identify solutions. For example, if a patient wishes to increase physical activity, but they feel constrained by caregiving responsibilities or even chronic pain, we don't tend to abandon this goal. We help the patient adapt strategies to fit their changing circumstances. So as life circumstances changes, so does the challenge, and we help within the service to adapt and grow with the patient needs and through continuous support. So it's a very flexible as well approach in the coaching. As well, like we said, the coaching is very focused on health and behavioral models. One of the biggest models is the trans-theoretical model of change. And this model proposes that the behavioral change occurs through a series of stages rather than a single event. So it's very important for us when we talk to the patient to understand which stage the patient is to help make the most appropriate coaching approach. So it starts by pre-contemplation. Pre-contemplation is when the patient is mostly unaware of the problem. So a patient can come and tell you that my diabetes is currently not a problem. I don't think I need to change anything. So at this stage, we focus more about raising the awareness before encouraging change. Then the patient can move to contemplation. And contemplation is when the patient knows but not sure what to do. So as well, they know, for example, they should be exercising more, but they're not sure they're ready to exercise. So here we explore more what prevents the patient from doing the actions. We kind of help the patient weigh the benefits as well and the challenges. Then the preparation stage. And the preparation stage is when the patient knows the action, has an action in mind, but is just still looking to do the action. So the patient can be telling us that, oh, I've decided to go for walking after lunch and dinner, but I don't know any walking groups, or I don't know how to do that. So the focus becomes more about identifying and planning these practical steps. Then the patient can move to an action. An action is when the patient already knows what's their plan and they actually can execute the action. So the action could be either walking 3 times a day, 3 times a week, and preparing my meals. So what we do as coaches is that we reinforce the success and help overcome any barrier. The patient then moves to maintenance, and maintenance is just focusing on sustaining this behavior for a long time and preventing relapse. However, we have relapse within this cycle, and within this model, we view relapse as a normal part of change process, not as a failure, because patients can encounter any different barriers in life that they cannot control at any point. So when a patient is mostly in a relapse phase, we focus more about reflections, learnings, and how they can re-engage. And they can move back to either pre-contemplation, or they can jump from relapse to preparation, or from relapse to action. So it's very useful model to help us identify and tailor the intervention and to assess the readiness to change, rather than applying a single approach or a one-size-fits-all approach. Another model that we use as well is the self-regulation model. And this model proposes that individuals form both cognitive and emotional representation of their condition, or of their diabetes or any illness. So for example, an example for that is that we might have 2 patients. They have the same HbA1c, which is the blood level test that determines that they have diabetes. However, they interpret this very differently. One patient can view diabetes as a manageable condition and feel confident in their ability to cope and make lifestyle changes. However, another patient can perceive it as a severe and a frightening and uncontrollable condition. So these 2 patients have 2 different beliefs, and these beliefs influence their behavior and as well their engagement with treatment. So during the coaching, we explore how the patient understands as well their diabetes, how they feel about their condition, how they have perceptions that may influence their self-management and behavior. And this is as well allows us to set the goals more accurately and to help support the patient beliefs, and to make as well any necessary referrals to other services that we collaborate with as well. So the benefits of the 12 weeks program that we offer, it's that during this 12 weeks, we have enough time to establish a rapport with the patient. We have enough time to kind of implement behavioral change and refine any strategies through the ongoing sessions and ongoing feedback. So we focus on the lifestyle, the dietary habits as well, with the medical advice. It could be from the diabetes nurse, it could be as well from the GP. The sessions can be from 30 minutes to an hour long, depending on the patient preference. And as well, it's a continuous kind of feedback. We have problem solving, we have emotional support, we have as well, we assess their motivation level each session for change and for action, and we set goals each session that are feasible, and we follow up on these goals. So the patients kind of have experience of early success when they achieve the first goal and they move on to their second goal, and this strengthens as well their motivation and confidence. So implementing healthier lifestyle. So when we foster this sense of control and ownership of their health, the patients are more likely to maintain this positive change. And this is the central mechanism when it comes to coaching and behavioral change, is the development of the self-efficacy. When it comes, for example, to the social cognitive theory, individuals are more likely to initiate and maintain their behavioral change when they believe that they are capable of performing them successfully. And that's what we try to enhance and in our coaching, the self-efficacy, to make the patients aware that they are able to do this these decisions. They can impact their life more positively as well. And while we support these small incremental steps, the patients have more ownership of their decisions and make more long-term success that's achievable rather than just small steps that they might give up or forget later on. So overall, if you want to describe health coaching, it's a patient-led journey. It's not about telling the patient what to do. It's just walking with them side by side. They lead the way while we support and refine the process and guide the process. So it's all about the patient. Each session is completely different than the other. Each patient's approach is completely different than the other. It's all about that autonomy that the patient have over their own choices and their own actions, and we help them prioritize these goals and make them more achievable and more realistic, and we support them. So it's a patient-led journny, and a big part of our program, like I said, is the cooking classes. The cooking classes are held monthly by the University of West London. And this is one of the patient's favorite things about the program as well, because in the cooking classes, we have as well a questionnaire, and this questionnaire helps the patients evaluate their cooking skills, their meal planning, and their food preparation. And during the cooking classes, as they attend, they can enhance all of these skills and all of this knowledge. And we give them the assessment in the first cooking class and the end cooking class, and we saw that an increase in the score from 104 to 172. And this is extremely important because cooking classes are extremely relevant when it comes to diabetes management, because it influences their dietary quality and the ability to implement their nutritional recommendations and to do their own shopping and to do their own portion size and their own cooking. And this is extremely important. So we cook in the cooking classes different meals, different cultural meals. The cooking classes are adaptable as well to the patient's requirements, and the patients have advice from chefs, and they cook their own meals and take them home and enjoy them as well with their families. Another tools that we use for assessment is the self-management tool, self-management assessment tool, and this is it's a questionnaire, a 10 questions questionnaire, and it evaluates their knowledge, their goals for the future, their daily routines, adjustment, emotional adjustment, and social support. These domains are very important as well when it comes to diabetes, because successful management extends beyond the medical treatment. It just requires their integration of everyday life, how they can do their daily routines, how much they have social support around them. And as well, we saw an increase in the score from the start of the 12 weeks to the end, from an average of 40 to 54. Another questionnaire that we use is the mental well-being scale. It's the work and environmental well-being scale, and it's widely used and validated tool as well to measure the positive mental well-being. It has questions about aspects about optimism, about psychological functioning, and as well social support and how much they're connected to their surrounding, and social well-being and psychological as well. Well-being is very important when it comes to self-care. And we saw as well an average increase from 54 to 61. Our last score is the IPAC, which is the International Physical Activity Questionnaire, and it's as well a validated tool, and it categorizes the activity level into low, moderate, and high activity based on the frequency, duration, and the intensity of the physical activity. So we ask patients what are how much they exercise for how long, and we all know how exercise is connected to glycemic control as well, and insulin sensitivity and weight management and cardiovascular health. So it's an important score when it comes to the holistic care of diabetes management. As well, when it comes to the most clinical score is the HbA1c. HbA1c, it's the blood test that determines what if the patients are pre-diabetic, diabetes, how much is their control. And we saw that in patients who adhere to the coaching, the lifestyle changes, we've seen that when they do the blood test by the end of the program, and this is blood test that's done through the GP or the diabetes nurse, we saw that there is an increase, a decrease in the HbA1c. So it decreases from, we have one case that decreased from 70 to 59. It's important to note that while we know that the HbA1c is an important factor, we know that we cannot say that the coaching itself did that, because the patients are as well on medication. The patient as well on either could be on insulin therapy, they as well could be, there are multiple factors that affecting the HbA1c. However, mostly when patients are, they adhere to their medication as well, they adhere to their lifestyle changes, they increase their exercise, they change their portion size, they eat healthier, the HbA1c tends to decrease by the end of 12 weeks. So it's all part of everything is an integrated care routine when it comes to the HbA1c. So what is long-term success through the coaching? The aim is sustained behavioral change. This program is built to foster lasting lifestyle changes rather than short-term fixes. The skills patients gain in these sessions and the cooking classes continue to serve them long after the program. And it's a strong foundation for health. By focusing on the empowerment and the self-management, patients tend to live with a higher confidence to control their health in the long term. And we usually take feedback from the service users, and some of the feedback we've received are the following. Some of them found the cooking classes very useful. They said, thank you for the cooking classes. I have enjoyed all 3 of them. It has given me greater confidence to cook as well at home. We look forward for each session, and because we have enough time to discuss and answer all of our queries. So as well, we have one of our case studies to talk about, and it's about a patient. We're going to name the patient Roman. This patient, was identified, he approached the service a year ago or a couple of years ago during an outreach event in Ealing Broadway. The patient was experiencing street homelessness. He had been sleeping in a bus shelters for 2 months, and he has been living as well with type 2 diabetes, and unfortunately had undergone amputation of 2 toes due to complications. The patient struggled to manage the insulin and other medication because he had unstable living conditions, limited access to a refrigerator, which is important for the insulin and the medication. Part of our service is to collaborate with other services and to signpost and refer. And one of these services is the RAM service. And this is a service that supports patients when it comes to housing and securing temporary accommodation. And in this case, the patient was referred to RAMS, and they were able to secure him this housing, and he was seen almost every week or every other week for the 12 weeks to support with understanding more about food choices and about the food, about what he should be eating, about as well medication. And he had support from other partners. The patient was discharged from the program when he finished his 12 weeks. He was referred again as well at the beginning of this year. So we do have referrals again in our service. Right now, the patient was referred again because he does have an accommodation. He does have a refrigerator. However, he is relapsed again and struggling with understanding more about how to have a healthy meals or how to organize his meals as well on his medication and insulin. And he had extremely high blood sugar levels and HbA1c. So part of our service is what we did is that we collaborated with DICE, the service that Adam will talk about as well, where he was, and we had joint sessions with the diabetes nurse. The information about what's insulin, medication, and all of this was explained to the patient more in details. The patient was given as well as CGM to monitor his blood glucose at home. And from the coaching perspective, we set goals weekly to help monitor his blood sugar and to help him with his eating habits. And we've been seeing the patient as well again for over the 12 weeks. And we noticed now by the end of the program, he reached the end of the 12 weeks, is that now he is able to take his insulin on time with the help of the diabetes nurse. He is aware what is a low blood sugar through reading of the CGM. He's aware how to act when his blood sugar is low, when to eat meals, to go for walks after meals. So he's been able to set goals to a healthier lifestyle as well. So this is the end of our presentation. Thank you so much for attending, and we will be taking questions at the end as well if you have any.
Thank you. Thank you, Rosa and Allah. It's a wonderful trip of diabetic people that they could have joining your team. According just on time, 2:30. According to our timetable, we are able to break now for 15 minutes. For a comfort break, and we're going to be back at 15 to 3 in order to listen to Adama's presentation, and then at the end of that presentation, we're going to take questions. So we'll stop for a little while, and we're going to be back in 15 minutes. Adama, do you mind if you put your slide up, the first slide, so there will be a kind of signal on that we are back and we're not going to be away. It will be 15 minutes. If you can share your screen, will be great. Thank you so much. And don't forget to unmute, later on the button. So what I've done, it's like I've shared and then I forgot the mic. I will, Adama, the floor is yours. You can start your presentation. It's 46. So if you are ready, then we can start.
Lovely.
Thank you so much.
Thank you, Amaya. Thank you for the introduction, and thank you for inviting me to this forum. So my name is Adama Oku. I'm the diabetes matron and service lead for the diabetes service in Ealing, and also an independent nurse prescriber as well. So we're going to talk more about what we offer in the service. I think the previous presentation has talked about the prevalence, what's happening around the world, and also in Ealing. And you can see from the information that diabetes is on the rise. And that's why we mentioned about prevention is now in conversation with NHS England. They're pushing for prevention now. But right now, we have what we call the intermediate service, and that's the diabetes service in Ealing. So I'm going to talk about what we offer, the challenges we face, and especially around health inequalities, the risk factors. But what you're going to hear more is about integration, collaboration, and also strategies that we put in place to help manage these health inequalities. Because I think it's very important to look at the theory, but I think the practical aspect brings it home and makes it more real. And that's why Ailing Diabetes Care was actually introduced in 2013. Before that, all the care was given in Ailing Hospital, and that's the secondary care. And I know with the NHS plan, it's about bringing care home. And we know with patients, lifestyle, they don't like going into the hospital. So we're now bringing it to the home in the community, and we're seeing much better engagement, although there's still some challenges to overcome as well. So what do
Excuse
you...
me, Adam. Sorry to interrupt. We still see your first slide.
I'm
Is it
still talking
okay?
through it. Yeah, that's fine.
Okay. Oh, wonderful. Apologies for that.
So I'm just talking through that. Lovely. So what do we offer in Ealing as well? So our service is what we call the tier 2, tier 3 service. So the GP practices that offer the tier 1, they do the annual review, they do all the 9 care processes, which is a part of diabetes management. But the complex patient that they can't support or manage, they now bring into referring to our service. So our criteria is different. It has to be a HbA1c of 64 and above. Patients should be on 2 or 3 oral medication, and then patients are being referred to our service to initiate insulin or GLP-1. And as I mentioned before, referrals can be from GP, from the hospital, from district nursing service. We work closely with them a lot, and also the care home. And the service module is a multidisciplinary module. We have the consultant, we have the diabetes matron, we have the dietitians as well, because we cannot manage diabetes in silo. It has to be joined up care. We have the podiatrists as well, we have the psychologists, and we have the admin team who sort out the registration and booking of the appointments for the patient. But I think the key point is the collaboration. We work closely with the primary care colleagues. We have PCM meetings, we have MDT meetings, and what we're hoping to achieve, because diabetes is on the rise, we can't do this alone. Referring everybody to the specialist service will increase the waiting list. So what we're doing now, I'm going to share what we're doing in the next slide. We're doing a lot of joint up care. We're promoting self-management and raising awareness. And that's part of the NHS 10-year plan, self-management. So we want the family to be involved. And I think Rosa talked about education. That sits under our service as well. We have what we call the Right Start education. And to show that we want to involve patients and the community, we have it in English, Punjabi, Tamil, and now we have the Somali group. This shows that we're looking at what is happening within the locality, looking at the demographic, which is important, looking at the culture as well. And what happens when they come to these sessions and we think they need more additional support, we can now refer them to the diabetes coaching team. And the feedback we're getting, especially with the cooking class, they love it. And that's why, because with this culture, remember the research that Arif did, they want to maintain what they normally eat. But with the diabetes coaching team, they individualize it. They won't change what you're eating, but how can you make it healthy? And that's why this session or the coaching service is very, very relevant as well. What else do? We do education for the GPs who have interest in diabetes. We work with the practice nurse. And I think in 2015, I did a session with one of the practices in Ealing, and that came up with the Saluja project or the module. And what we did, we went into the GP practice just for 6 weeks, upskilled the nurse, teach her how to do the assessment, how to review medications in a timely manner. And the dashboard came from red to green. And that's what the approach we're adapting now. Upskill, and that's the only way we can manage diabetes and get better outcomes as well. What about technology? Everybody's aware of technology. We use CGM as well in primary care, in our clinics, with the care homes now, and we're using it more with the district nursing service. Currently, we're running a academy program, and that's working with the diabetes nurse and the district nursing service, looking at patients they see at home to administer insulin. And the audit is showing the caseload is growing. So with CGM, we're now reviewing the medication. We're either optimizing the medication or we're deprescribing based on frailty, HbA1c, reducing the risk of hypos. All this is important in reducing hospitalization for our patients as well. And that's all part of upskilling the carers as well to know what to do, when to escalate, and that will reduce reliance on the district nursing service in Ealing as well. What else do? We do a lot of outreach program and health promotion. This week is Diabetes Week. We've already set up an event this coming Wednesday where we're going to meet the public and we're going to do screening. So just health check screening. I mean, Alan mentioned somebody who is homeless. These people need to be supported. We mentioned how many people are undiagnosed with diabetes. This is how to capture them. If we see any abnormal result, we give them a letter to go to the GP for further investigation. So these are part of what we offer in DICE, and it's all part of the MDT. We involve other services. We have the smoke-free services as well. We have the oxygen service as well. So they do spirometry, and you'll be surprised how much they're picking up. Who didn't know they have COPD or lung disease? And this is the engagement, the community events that we run in the community to help to pick up these patients as well. And we also work with volunteers because we know language is important. When you speak to patients in their own language, they get the message. So this is all part of what we're doing in Ealing. I'm not going to go through the prevalence because I think it's been mentioned in the previous slide. But looking at this slide, you could see the dark purple area is North and South Ealing. It shows the prevalence. Why is that? It's the culture, it's the risk factors, it's the patients that live around our locality. And it shows that we need more work to be done to reduce this complication. And this slide is what I picked up a few years ago, showing the prevalence of diabetes worldwide. And unfortunately, it's not slowing down. It's spiraling out of control. What are the challenges do we face, though, in clinic? In order to manage our patients' diabetes, if they're on insulin, they need to test their sugar levels. And the patients complain they can't prick their finger, it's painful, it's the timing, their lifestyle as well, their walking shift works. Some people have low sugar levels and they're not aware of it. What's the risk of that? Hypo, they have falls. When you fall, you break your hip, you end up in hospital. Affects your quality of life. Hyperglycemia is also rampant in our clinic. Why? Because they're afraid of low sugar readings. How are we managing this? That's where we get this CGM. Because we know managing hypo and hyperglycemia affects quality of life. And when we mean quality of life, we're looking at diabetes burnout. This is actually a real term because patients get tired. It depends on the duration of diabetes. They have to take their medication, they need to go for appointment, they need to have insulin, they need to look at the timing of the insulin, the storage of insulin. Can they drive with insulin? We have patients who are bus drivers who can optimize their medication because they don't want to lose their job. These are all real things, challenges we face in clinic. But why is it important to manage this condition? Because of all these factors that we've listed here. If you don't manage your blood pressure, you might lead to stroke, heart disease. If your sugar levels are constantly high, it will now cause bleeding at the back of your eyes, leading to retinopathy, and then blindness. So this is why awareness, knowledge is power, would help patients to now engage with the services available in Ealing. Heart disease on the increase, kidney disease to enter dialysis. That means you have to go to the hospital 3 times a week for this. That's affecting your life, your quality of life. Your family has to take time off to take you. So if we can prevent these complications, which Rosa mentioned in her slide, is costing 10% of the NHS budget, is going to all these things that we've listed here. It's not even diabetes, the complications resulting from not looking after ourselves is resulting in the cost to the NHS. Look at neuropathy, peripheral vascular disease. I saw a patient in clinic last week. He's lost his sensation. He can't feel anything. And he's a driver. So what's the implication for that? He may have to stop driving until he gets his feelings back. That's if he gets it back. And that's why early intervention is important. We want to engage the patient. So education, we're pushing it in your language. We do it on weekends as well. We do it online. Anything hybrid to engage patients to now take control of their diabetes. So one of the tools we're using is what we call the flash glucose monitoring or continuous glucose monitoring system. And that helps to monitor your sugar levels, interstitial fluid. From there, you can detect the trend and it tracks the profile of your sugar levels. Because if I give you a blood glucose meter to check your sugar levels before breakfast, before lunch, before dinner, we know in reality most of the patients can't achieve this. But the benefit of flash glucose is you scan on the go and we can see the map, you can see the trend. I have a picture of one of them. And what it does, it helps you to take ownership, to look at what you're eating. Is what I'm eating, is it affecting my glucose level? Am I exercising enough? Am I eating too much carbohydrate? When you see your sugar levels peaking on the screen, which you're using with your mobile device, it makes you to reflect and say, okay, what else can I do differently to improve my outcome? We do have the national guidance that sets the criteria for eligibility for Freestyle Libre sensor or the DESCOM. It's kind of limited for people who have learning disability, who are relying on family, but we're hopefully pushing for everybody who's living with diabetes to be able to have access to this. And we do have our patients who actually self-fund this just for 2 weeks, and they can see a change in their diet. And we've noticed people are having reduced HbA1c and even going into remission just because they can now see what is happening in a timely manner, and that will help them to now make changes to their diet. So these are the criteria at the moment for people who can be prescribed the sensor. So in my clinic, we have people living with type 2 diabetes on 2 or more insulin. They do meet the criteria. But I think we're pushing the boundary now because we can see even on once daily insulin, if we can get you to engage, you might even come off insulin or reduce the amount of insulin that you're taking every day. And like I mentioned before, we're working closely with the district nurses. We give them the Freestyle Libre. The family members can now scan the sugar readings in the evening, and we can look at this remotely. And that's what came up from the COVID. We can view people in hybrid mode virtually and then make a clinical decision as long as the risk factors has been assessed. What about people with mental health? We know they don't engage with services. We know people with dementia, that's a massive challenge as well, and people with learning disabilities. So we're fortunate they meet the criteria to have this continuous glucose monitoring system, and that will help us to optimize their medication in a timely manner as well. So it's a simple patch that you attach to your skin, like you saw in the pictures below, and you can scan it up to 8 times, and we see the readings on the Libre view, which I'll show you some of the reports that we've got. And we look at the trends in the sugar readings, and especially if you're driving. I think now DVLA guidance have changed now. Before, you cannot use this CGM to scan when you're driving and use that as your final report. They still want you to use that. However, you need to do finger pricking just in case there's any change in the readings at all. So that's what the sensor will look like. We now have a sensor clinic because we know the demand is high, and also to use our time in a timely manner. So we now have our HCA running this clinic once a week in the different sites, one at Grand Union Village and one at Featherstone Clinic as well. So this is a case study of a patient. She's a female, young lady with high HbA1c of 100, and she's on 4 times a day insulin. You could see the amount of insulin she's administering per day. High BMI, that means she's overweight. Her sugar levels was erratic. And what was happening is because she didn't have the sensor, she didn't know she was running low and she kept feeding it. And that's what our patients do. But we call it hypo-rebound. But once we gave her the sensor, we can see the pattern. If you can see here, the following week, you could see the number of hypos she was having. And she wasn't even aware of this. But once we started reducing her insulin, adjusting her insulin, you could see the hypo stopped and her sugar level started to stabilize. And what was the outcome finally? We could see from this graph she was running low overnight. So we had to reduce her long-acting insulin to prevent the hypos from happening. And this is about quality of life. When you wake up with headache or you wake up with having a vivid dream, that means you're running low without you knowing. And this CGM device is actually helping. It's a game changer, helping us to pick this up and adjust medication safely. You can see a graphic image of the red spots showing very low sugar readings. And then because somebody, when you notice your sugars are low, the automatic thing to do is to treat it with your Lucozade or orange juice, and then have your meal, which will push up your sugar levels during the day. So it's like you're chasing your tail because you didn't know your sugar levels is dropping. So that's why when we see this report, we adjust the medication, reduce the insulin, and that patient will stabilize. And what was the outcome for the patient? She was trying for a baby, and then her HbA1c reduced because she has to have good control before you try for pregnant baby, and now she's now having a baby now under safe control as well. We mentioned mental health as a challenge, and in our service we did an audit to see how many people have been referred to diabetes service have a mental health condition. And we know that 1 in 4 living with diabetes suffers from mental health. It could be depression, anxiety, any form. But what is the challenge we have? They don't come to clinic because of diabetes distress. Some have what we call phobia. I have a patient, he wouldn't go on insulin because of a needle phobia, and this was when he was young. You have to explore. So there's so many things that is affecting patients' care, and we had to now think in our service, what else can we do differently rather than keep inviting them to clinic and they don't attend clinic and then you just discharge them. So, but from the audit, we now felt, okay, let's go in and see, can we do a joint clinic? Because this is what happens in diabetes. Depression will affect your lifestyle, the quality of food you're going to eat. If your mood is low, you're not going to go for vegetables. You're going to go for maybe sweet things, chocolate, all these things. Would you be active? No, because if your mood is low, you're going to be sitting in one place. Lots of mental health patients smoke a lot as well, maybe due to peer pressure, or maybe that's how they manage their symptoms. Sleep disturbance is big. I don't think we ask a lot about sleep, but there's so much research showing that not sleeping enough can actually increase your risk of type 2 diabetes or make your condition worse. So these are things that we're now bringing into the clinic, the strategies we're now looking into to say, how can we manage these patients to make sure they get better outcome as well. So what we did, we went to one of the mental health clinics in South, or they had their away day, and we presented our finding and what we're hoping to achieve. And we're fortunate they engaged with this discussion. We said we've already done the audit, they don't come to clinic, they DNA all the time. So we now agreed maybe we can run a clinic in their own service, because we know the mental health patients come for their weekly injection. So can we see them there? Can we do the physical health there? And this started actually in 2025, and the outcome has been positive. Those patients that don't come to clinic, because they now see my nurses in their own mental health setting, they have built that rapport. They feel comfortable to now come for the follow-up in the clinic. So what we've done, we set up a half-day clinic with the mental health thing. It was a pilot scheme, and what we've done is to see the patients alongside the mental health nurse. We review the medication, look at their diabetes, and we've seen so many examples which I can't share today of patients with prevented hospital admission. People we've referred for podiatry because they couldn't see. This patient was had a high BMI, couldn't see her feet, not knowing that she was nursing a wound, and because the nurse went there and checked it out, we now refer the patient to the podiatry. So these are the positive outcomes we're getting. Our diabetes psychologist has also presented in Belfast how we're integrating and working together, because this is the future. We cannot work in isolation, so we need to integrate with other services, which we're already doing, as you can see from the presentation we've done today. Even the psychologist does a group education for people with mental health to see how they can be supported in their own within their own setting as well. So this is the audit we did in diabetes service to show that there is a need. Many people refer to our service have one form of mental health, and we needed to do something about it. And so far, this is the outcome. It has been published in the Nursing Times. 30 patients with poorly controlled diabetes, they're tracked closely. We've actually now involved the phlebotomist because we know the patient don't go to the GP, they don't go to any appointment, so blood test is out of date. So from this project, we've now included the phlebotomist who come to the same clinic. We give them the blood test form. The blood test is done there. So it's kind of like a one-stop shop. So you come there, you see the dietitian, you see the diabetes coaching team. The next plan is actually to involve the smoke-free team to actually come there because we know that people with mental health smoke a lot, and how can we support them with this? And we're reviewing this every 6 months, but the clinic is actually run once a month on a Thursday. And we're seeing better engagement, better involvement with both services. And this is the trust strategy, working together, integrating care together, and not working alone as well. This is just a snapshot of what we do in diabetes, but thank you for listening.
Thank you so much, Adama. Beautiful summary of your many activities. So thank you so much to all presenters. And now it's the time of the participants that are able to send us their questions, and would be happy to answer for all the panelists. So please feel free to type your questions, and then we can start the discussion on our on our services and so on. And I can see that I've got quite unstable network connection. So just in case, Rosa, that I would need your support.
Yeah, no problem.
Yeah,
we'll just give it a minute just to see if anyone's got any questions.
Yeah, thank you.
Feel free to put them in.
Yeah.
The chat.
I'm not sure if people are shy, but I think there's opportunity. If you're in West London, you might actually maybe want to visit the cooking class, or if you want to come to our service to shadow to see how we run our clinic, that can be a good opportunity as well. And then you can share this as well.
Definitely.
I think that I'm not quite sure about these specific participants now. However, we've got an international body of people that will reach out. But I mean, if you are fine, what we can do is we can share our email account, and probably some of the people that they would like to know more about the project or the services and the communications, they may be able to do so. Yeah. So when are your clinic days? Antonia is asking. So I guess that those clinic days maybe probably it's for you, Adama.
Hi, Antonia. So we do clinics at different sites. We have a Grand Union Village in Northolt, at Featherstone on Wednesday, Thursday, and Friday, and also at Acton Health Center, Tuesdays and Fridays. So you can see we're kind of catching for the whole population so that people are not traveling, and that will help to reduce DNAs as well. So you can send me an email if you want, and we can arrange for you to shadow or visit our sites.
Thank you. Yeah, and from our side, we also have three set clinics: Acton, Featherstone, which is in Southall, and Greenford Green, which is in Greenford. For those that aren't local to Ealing, we spread ourselves across the borough, just to, as Adam has said, reduce barriers to engagement. But we also run remote sessions within the coaching service because they are that one-to-one consistent support. So that patients can contact via video call or over the phone if they'd prefer as well, or if they have mobility issues that might impact their ability to engage face to face.
We've seen one question. Rodrigo, I'm not going to pronounce the first name. Thank you for thank you for that you find interesting our presentations. How are you able to capture older Asian patients that do not speak English and have access barriers to get to those clinics? I don't know, probably Adama, you can start with Asian patients. I know there are some pockets, quite a lot of pockets within Ealing because of the Planetary Food and Cultural Competencies Project. However, I mean, you know your borough really well, Adama.
Okay. Thank you. That's a good question. I said we work closely with the GP, so GP send the referral to our service. But I think we're very fortunate. Our admin team speak the language. So when we send out the invite to register for the education, we know half of them don't get back to us. And sometimes the phone number is for their daughter or their auntie. So what we do, we actually ring them, and in their language, we now offer them the Punjabi session. And what we're hoping to do in the future is actually to go into the GP practice and run the session, because we know they're familiar with that environment. So that's the future plan. So we do have Punjabi session, and if other cultures can't get access to the education, we have the No Diabetes website that is translated in so many languages, Polish, Arabic, and as well. But in the South Asian population, I think is well served, and they love it when they come to the session, because who is teaching them is somebody that speaks the language, not through interpreter. So it's the language of the heart.
And then we also, Adam has shared all about the community engagement that we do, and I think that's really key for particularly some of our older adults who might be less able to travel to a location. So one of our biggest events of the year is actually at the local Gurdwara, and there's a lot of the older Asian population that attend the Gurdwara, so that's a key place where we engage. And we make a real proactive effort to also, where we know that we might have maybe that language isn't spoken within our team or within the wider service, to arrange for NHS volunteers to attend who can translate for us as well. So we'll work also with volunteers who's also typically young students who really want to get experience within the NHS. And working with local services, so that's also a great opportunity to offer to people within the community as well. And we also have a brilliant contract with a local interpreting service. So when our coaching sessions are delivered over the phone, we can also call in interpreters and do a 3-way conversation for that clinic session.
And the outreach at the temple is very popular. You need to see the queue.
Very, very popular.
Thank you so much, Rosa. Thank you. You did say also that you are communicating with a phone, I think, or something like that. So, because it says about access. So
exactly, so then that can be taken virtually, which is a lot easier to set up the interpreter as well.
The sessions that you are delivering also could be also online.
Yeah.
I've got connection issues, so apologies if you cannot hear me
No,
well.
don't worry.
But please, if there is a question and I cannot respond or I'm, freeze, please feel free to answer.
Okay.
Perfect. If there's no other questions, I'll put our email in the chat. Adama, if you have your do you have a shared mailbox that you could share if anyone has any questions?
Can put it in the chat.
Yeah, in the chat is fine.
Okay. Yeah, you've got it there. Thank you. I don't think that the chat is been recorded like with the emails, because this session is going to be uploaded at the central JBI. So probably we can write your emails underneath to let the international team of diabetes to contact you, if needed. Yeah.
Or they could fly me out,
Yeah, absolutely. Absolutely. It's a great place. I've been to Adelaide, and
Really?
yes, and there is a big consortium, like a big conference sharing practice. Every year, it's annual.
Wow.
Biannual for Adelaide, and then another center is hosting, and then it goes like that. And it's a great opportunity for share practices. I've learned a lot. Yeah, really nice.
Brilliant. Thank you so much, everyone.